Welcome to the Special Operations Medical Association podcast series on prolonged field care. Any opinions contained in these podcasts are those of the authors alone and do not reflect U.S. Army, DoD, or U.S. government opinion or policy.
Probably about 4 or 5 months off, maybe worse. Yeah, sorry about the big gap in time, but it's important that you guys know everybody working on this prolonged field care working group has a day job. So a lot of us are relatively senior people in our organization, so working on things like podcasts gets trumped real quick by a lot of other things happening in the world. So anyway, welcome back. Thanks for your patience. So we need to finish up the last section that we were working on, which is on pharmacology, which is by far the topic that people have the most questions about and where we can really benefit from listening to subject matter experts talk about their trade. So today I've got Lieutenant Colonel Jim Reed, retired. So Jim is a former 18 Delta, and he's been a CRNA for a number of years, lots and lots of combat rotations. So Jim has a wealth of experience in terms of understanding what it is that we're trying to accomplish in the prolonged field care setting, as well as how that relates to his practice and then what can be applied. All right, so before we dig into the conversation I had with Jim Reed, I'm going to reference a couple articles here. So these are going to be in the show notes. So the first article that's in the show notes is called Ketamine in Pre-Hospital Care. That's from the Emergency Medicine Journal in 2004. So yeah, I know it's an older article, but it's just a couple pages long and it's really, really good and focuses entirely on how ketamine was used in the UK in the pre-hospital setting. So for example, right in the middle of the article, it gives you this table with 32 different examples of how, when, and why ketamine was used pre-hospital. For instance, one right here, there was a sports injury, fall from height, 30 feet, and it was a climbing accident. So there was a head injury, blunt chest injury, agitation, and a right wrist fracture. So to facilitate management and packaging of the patient and everything they had to do, they gave 50 milligrams initially, then they gave another 20 milligrams and another 20, and that was it. So they gave 90 milligrams total for this entire case in the field. Pretty cool. So a lot of the times the questions that we get are, how much ketamine do we need to bring with us on a deployment? And so one of our goals as the working group is to figure out ways to help you plan out how much medication you need to bring, how many actual vials of ketamine you should have in your drug box, and what you're going to need to take on this whole trip. So this article gives you 32 great examples of how much ketamine was used on a bunch of different cases in the pre-hospital environment. And on all of these cases, one vial of ketamine did everything they needed it to do in the pre-hospital setting, but that doesn't include the prolonged field care setting. So we're going to get into how many vials of ketamine you'd probably need to bring in order to hang a ketamine drip so that you can keep a severely injured patient sedated for a long period of time. So the other thing you're going to find in common with all the articles that we've posted is that they do a great job of explaining what ketamine is and how it works right off the bat. So when we talk about learning these medications inside and out and being a professional and knowing the medications that you carry very well, just reading these articles and reading through just the first few paragraphs where they talk about what ketamine is and where it acts and how it has dissociative effects, but it's also a profound analgesic. All these things are in each of these articles. So when you read them, you're really going to get a handle on the medication. This article also brings up a really good point. It says that when they're talking about ketamine usage in the field, they're talking about ketamine in sub-anesthetic doses for analgesia alone. So this is a really important distinction that we're going to get into in a little bit. And it might seem like a bit of semantics, but really when you're talking about using ketamine pre-hospital, it's really important that you understand which of the three things we're trying to do with the medication. So number one, we're talking about adding a little bit of ketamine onto the pain control you've already started with opiates. So you've given some morphine and you're just going to add a little bit of ketamine on board to really enhance the analgesic effects of the opiates, but you're not going to snow the guy with ketamine. Use number two would be procedural sedation. So supposing you want to put in a chest tube. So the patient's doing okay in front of you, but now you've got to do something really painful, like put in a chest tube or set a fracture, or maybe the patient's entrapped in a vehicle. You need to get them out, and it's going to be really painful. So you need to sedate them just for about 15 minutes to get a job done, and then you can reassess them and work on the pain control strategy after that. but you're not looking to completely snow the guy with ketamine for a while. You're just looking to get a procedure done. All right, and then the third use for ketamine would be for prolonged sedation. So this isn't really addressed in any of the articles, and this is why we're consulting with the subject matter experts here. And what we're talking about in this case is hanging a ketamine drip, a ketamine and Versed drip. And what we're trying to accomplish with this is a prolonged period of sedation. And this is really where we get into the unique aspects of prolonged field care, because there's a lot of analogs to the civilian pre-hospital environment in terms of ketamine usage, but not really this one. This is where we're talking about you being deployed in a very remote area with a guy who has severely painful injuries, or supposing the guy has a broken pelvis, and you need to move that guy 5 hours over rough terrain in the back of a car just to get him to an airfield. Well, yeah, you can probably get the job done with an opiate analgesic strategy and bumping some ketamine in there, maybe. But the right thing to do is to get that guy totally sedated for the trip. So you're watching the guy's airway the whole time, but you've got him sedated with ketamine. And if we're talking about a 5-hour drive, that's going to get really complicated in terms of giving the guy bumps of medication. So the right thing to do there is to hang a ketamine drip on the guy. All right, so the reason this is really important that we understand how and why we're using ketamine is because when anesthesia providers talk about ketamine, usually they're speaking of it in terms of an induction agent for general anesthesia, and that is exactly not what we're trying to do. What we're trying to do is use sub-anesthetic doses for either pain control or for procedural sedation, or to hang a ketamine drip to keep somebody sedated for a long period of time. And this is why it's essential we talk to people like Jim, who are anesthesia providers who understand the prolonged field care setting and the special operations medic, so that they can translate what they do into how it relates to the prolonged field care setting and make sure that we're on the right track. So this strategy revolves around using a 250 bag of normal saline and 750 milligrams of ketamine set at 50 mLs an hour for a 90 kilogram patient. So we're going to get very in-depth in terms of how to set this whole system up and what it's supposed to do for you, and why it's a 250 bag and why it's not a 500 ml bag or 50 ml bag. So we'll get into the weeds on how this whole thing works a little bit later. All right, so back to the articles. The second thing you need to check out in the show notes is an article from Military Medicine in 2006 called Ketamine for Procedural Sedation and Analgesia by Non-Anesthesiologists in the Field. Long title. Okay, really cool article, and the way they talk about ketamine is they use the term PRSA, procedural sedation and analgesia. And so what they're talking about in here is how useful it is in the pre-hospital environment, and the things you can get done. But they make some pretty bold statements in here that you need to pay attention to. So right up front, they talk about, just like the other articles, they talk about what ketamine is and how it works, and it's a dissociative and whatnot. But one thing that kind of caught my eye in here is they say, once a person is dissociated, a patient will not respond to pain regardless of the procedure performed. A provider can perform an arm amputation or a simple laceration repair with identical PRSA conditions. So that's a pretty bold statement, and a few of the anesthesia providers that I've showed this article to, they kind of looked at that line right there and said, yeah, that's kind of weird. I don't know if I would have said it that way. And so I think it's important that we discuss this for a second. So the intention of the author there is to let you know that sedating somebody with ketamine is not rocket science. And just because you're doing something really painful doesn't mean you need tons and tons of ketamine to get it done. However, the way they worded that makes it sound like the procedure being performed is totally irrelevant to how much ketamine you're going to give. And that kind of flies in the face of what we've been talking about in terms of figuring out what it is that you're trying to do in terms of the three things that ketamine can do for us in the prolonged field care setting. The next thing is they say that ketamine is given as a single bolus for procedural sedation rather than repeated small doses titrated to effect. So that contradicts a lot of what we've been putting out here. As far as the prolonged field care working group is concerned, we advocate for titrating to effect smaller doses of ketamine. Yes, you can push a large dose of ketamine. You can push 100 milligrams straight off. In our opinion, there's no reason for you to do that. You should do 20 milligram bumps and walk up to the nystagmus versus just giving somebody 100 milligrams rapidly through their IV. All right, so article number 3 is called Ketamine for Pre-Hospital Use, a New Look at an Old Drug. This is a 2007 article, another great article. And the cool thing in here is they bring up the fact that they gave ketamine to somebody who, in a number of cases, who were already hypotensive. And ketamine was considered safer than repeated doses of narcotics. And it says, as with the cardiac patients, none of these had any drop in their blood pressure after ketamine doses. Their conclusion is great. It says, ketamine is an ideal drug for use in many pre-hospital situations. Our experience suggests that it is safe, effective, and may be more appropriate than drugs currently used by pre-hospital providers. All right, and the last article that you absolutely have to check out is called A Clinical Practice Guideline for Emergency Department Dissociative Sedation with Ketamine. All right, so this gives you an actual clinical practice guideline that's in use currently in the United States. So if you encounter some pushback about wanting to add ketamine to your guys' formulary, this is a great way of saying, hey, this is how it's done, and this is how we would, these are clinical practice guidelines that we would abide by, if we're going to bring ketamine on a deployment. All right, so enough out of me. Let's hear what Jim Reed has to say about this stuff. So please check out those articles on prolongedfieldcare.org. Have a read and read them a couple times so that you can really master this drug. So the first thing I get into with Jim is about the decision-making process, about when you would actually push ketamine on top of the opiates that you already gave somebody. Because if you look at all the different guidelines, the TC3 guidelines and the TMEPS and whatnot, it assumes that you've probably already tried to control somebody's pain with the opiates. And so my question to Jim was, when do we shift to ketamine? What's your trigger to do that? And so this is his response.
Okay, understanding where they both work. Opioids work in two different places. They work centrally in the brain to kind of give you this euphoric feeling. And they work actually in the spinal cord, and they can work in the periphery even, because there's opioid receptors everywhere. The ketamine does the same thing. It works in the brain, and it's a dissociative, so it works at the thalamus. But it also works in the dorsal horn, very near where the opioids are working, to basically stop the pain there at the dorsal horn from getting up to the brain. That nerve, that pain stimulus. The key with ketamine for pain control is, no, it does not take a lot. It's not, for pain control, it's not the same as making them sedated, and it's not the same as making them anesthetized. 10 milligrams at a time, coupled with an opioid, I wouldn't just do a single agent technique. It's in my nature anyways to use multiple things to affect an anesthetic or a sedation, etc. So if I was a young medic and I didn't really know, or I wasn't feeling very comfortable, hey, look, you got to get comfortable being uncomfortable, number one. Number two, rely on what you're taught. So what the TC3 committee said was low dose ketamine, and I completely agree with that course of action. As an anesthesia provider, low dose is fine. 10 to 20 milligrams is more than enough to mitigate what I was talking about in the dorsal horn where ketamine works at that NMDA receptor. It's more than enough. You just have to give it time to work. It's not going to work so fast where you're not going to notice that all of a sudden they're just completely pain-free, but you're just trying to take the edge off. They may still be hurting. And if they're hurting, guess what? They're also breathing. If they're telling you they're hurting, they're breathing. So there's a few things that you want to try to get out of your head. Is you're never going to make anybody completely comfortable. But what you want to do is try to get a sense that if the patient is a 10 over 10, do you think they might be able to do a little bit better with a 7 over 10? Because you don't have the expectation they're going to be pain-free. Because pain-free is anesthetized, period. And you're not qualified to do that. I don't want you doing anesthesia on somebody who all he needs is some analgesia. If I've cut the pain in half, hey, it's in half. So that's better than a 10.
All right, so my next question to Jim was about the dosing for ketamine for procedural sedation versus what we just talked about, which was augmenting opiate analgesics with just a little bit of ketamine. So we kind of just went on a tangent about how you would sedate somebody for a ketamine cric.
Now, you talked about procedural sedation for a cricothyrotomy. It's going to take a higher dose. It's going to take somewhere, almost an induction dose, because the airway is very sensitive. How do you mitigate that? I would use local anesthesia. I would numb up the neck, and then I would do a transtracheal anesthesia. So if you have 2% lidocaine, right where and you've got time, they're not in extremis and they're not dying at the moment, because otherwise hypotension is going to probably be your anesthetic anyways, and you just got to cut a hole in somebody's neck. But if you've got time, say it's somebody who took a blast to the face, and I've had to do this before, put them in a position of comfort where they can still ventilate. For example, I had a guy who got shot right in the face, and he's bleeding all over the place. I criked that guy while he was sitting up with local anesthesia and a little bit of ketamine, probably bumped in 25, maybe 30 milligrams with a couple of milligrams of Versed up front. I localized his skin, and then I took an IV catheter and I went through his cricothyroid membrane, and I squirted about 3 mils of 2% lidocaine in there, and it numbed his airway up. That's how I did it. It worked great that time. Again, I was able to keep the guy sitting straight up, kind of leaning a little bit forward, and he was bleeding out onto my hands and everything else, but he did fine. Again, you're going to have to assess the situation. How cooperative is a patient? What position can they be in? But again, local anesthesia, I'm a big fan of it. And it will help you decrease the amount of other parenteral drugs you're going to have to give. If you're going to do that cricothyrotomy like you talked about, and it's an extremis situation, you may or may not have to use a ketamine. If you have to use a ketamine, then go big, and then just hope you get the tube in. Give 2 milligrams per kilo. Give an induction dose, and then have somebody there waiting to ventilate the patient. Or you can go maybe just a tad bit low, a half to 1 milligram per kilo, but you're going to want to make them still, and to do that you're going to have to go give a fair amount to make them still and cooperative, because when you cut into the trachea, the body will react to that. And that's why I kind of like to use the local in there, to get dissect all the way down to the cricothyroid membrane, and then just squirt 2 to 3 mils of local anesthesia into the trachea itself. The patient should have airway reflexes. They'll cough, and what that will do is that will push all that local up and around to the bottom of the vocal cords. It effectively numbs up the recurrent laryngeal nerve. Does it happen instantaneously? No, it doesn't. But it does help. It takes 30 seconds, maybe a minute for it to happen. But if you're an extremis, God bless you. Do the best you can. There's no magic bullet here, and it's one of those things where you're just going to have, if you're going to make an error, make one of commission. Just do something. But the bottom line is air's got to go in and out. And if that doesn't happen, then it's a bad day.
All right, so just to recap, when we're talking about procedural sedation using ketamine, the airway is different. So what Jim was saying here is you're talking about induction doses to put a surgical airway in. So you're probably looking at 100 to 200 milligrams of ketamine, just due to the sensitive area that the airway is. All right, my next question to Jim is about keeping a patient sedated over a long period of time. So I gave him the example that maybe you have somebody who was burned and you've got an ET tube in their throat, or you've criked them and you need to keep them sedated for like a day and a half or whatever your prolonged field care timeline is. And this kind of goes into that 250 bag of saline with 750 milligrams of ketamine in it, that you're hanging this ketamine drip on the patient for. So this is Jim's response about how you're going to keep the patient sedated.
For an ET tube in their throat, because I've always been told that's a huge kind of pain stimulus for the person. And
it is.
Okay.
It is. But it'd be Versed, ketamine, and an opioid.
Okay.
And run it just like you did. Once you got a secure airway, again, I'm how am I going to do it is going to be different than how a medic's going to do it. But that would be a reasonable way to accomplish this. Is your 750 of ketamine in a 250 bag, titrating in fentanyl, a benzodiazepine up front, perhaps to give them a little bit, if their pressure will tolerate it. Jim Reed, would do it a little differently. I would probably go that direction with the ketamine drip, but what I would also add to it is vecuronium, because I want to take control. I don't want this patient moving. I don't want this patient dislodging his lines. I don't want this patient dislodging his airway.
All right, so just to reiterate, Jim is talking about using vecuronium, and that's not something we're advocating that we do in the prolonged field care setting. And he is saying, though, that the 750 milligrams of ketamine and the 250 bag with the Versed is probably going to do the job. All right, and so since Jim was talking about vecuronium, I'll just go ahead and say that we're going to cover RSI in a future podcast, because I know everybody wants to talk about whether or not soft medics should be doing rapid sequence intubation in the field and using the paralytics like succinylcholine or vecuronium. And so this is a much longer conversation I had with Jim, so that's a whole podcast of its own. All right, so to round out these talks on pharmacology, the next one we're going to record is going to be on just how to build these kits, how to build the 750 of ketamine in the 250 bag, and why we have it set up that way and what it's designed to do, as well as how we recommend that you should organize your medications when you deploy, and what a sample kit would look like. All right, so thanks for listening, and check us out at prolongedfieldcare.org for the show notes.